Donc, Nicole est en stage. So Nicole is in her internship with Yusuke. And you are currently at Rennes for the integration module, right? Both students are at the integration module in Rennes. And so thank you for taking your time out of the busy teaching program, probably. And so we're looking forward to hear your presentations.
Yes, thank you, Judith, for the introduction. So yes, as she said, my name is Nicole, and I'm currently doing my internship at Institut Pasteur over the past months. And I've been working on this project, so I'll be presenting the findings that we currently have, and I welcome your inputs to make the project better. And then, yes, so the project that I've been working on is on delayed access to different diagnostic tests and its impact on accurate diagnosis of hepatitis B-related liver diseases in Burkina Faso. So just to give you a little bit of background on why this project is relevant, given that hepatitis B virus might not be a subject of interest in some countries. However, globally, 254 million are living with hepatitis B virus globally, and there were about 1.2 million new infections in 2022. And while this shows a high global burden, the virus disproportionately affects the African region, where 63% of these new infections occur. And in addition to this global, this high burden, there is also barriers to healthcare access, as only 4.2% of the individuals with HBV are diagnosed. And among those, only 5.5% are given antiviral treatment. So today I'll be focusing on one country in the West African region, Burkina Faso, where the prevalence is estimated at 9.41%. Hepatitis B virus is a preventable and manageable disease, and the WHO has set an elimination target by 2030 with a target of 90% diagnosed and 80% of those who are eligible for treatment treated. However, to be able to get to that target, it is important to understand the natural history of HBV. So when someone is diagnosed with hepatitis B, when the infection persists for more than 6 months, then the patients are diagnosed with chronic hepatitis B. And among those patients with chronic hepatitis B, there is a risk to develop fibrosis, which is a liver complication. And this liver fibrosis presents different stages, as can be seen on this slide, from F0 to F4, representing the level of severity, with F4 being the last stage of fibrosis. And patients with cirrhosis, which is F4, have a risk to develop hepatocellular carcinoma, which is the most common liver cancer, and even have a higher risk of death. Among patients with chronic hepatitis B, there is an estimated incidence rate of 1.6 to 9.7%, indicating the risk to develop cirrhosis, but also further complications. So it's very important to monitor the patients with chronic hepatitis B to be able to initiate treatment on time. So once a patient is diagnosed with an HBs antigen test, they require other tests to assess treatment eligibility in order to initiate the antiviral treatment. However, this treatment eligibility assessment is based on 3 factors: viral replication, which is measured using HBV DNA, indicating the viral load. And in contexts where it's not available, HBe antigen, another test, has been suggested in settings where HBV DNA is not available. The second aspect that I had mentioned earlier is fibrosis. And to stage fibrosis, a FibroScan test is used, which is an ultrasound test, which is not invasive and has been suggested to stage fibrosis. However, in settings where it's not available, platelet count has been suggested to be used to calculate scores that can help to stage liver fibrosis. And finally, the third factor to determine treatment eligibility assessment has been liver inflammation that is indicated using two enzymes, ALT and AST. So it's very important here that I mentioned that HBV viral loads and FibroScan are very costly in resource-limited settings, about 40 euros in Burkina Faso. And its access is very limited, not only because of the cost that I just mentioned, but also in some settings, the equipment is not available. So to ease the decision for treatment eligibility assessment, major liver associations have developed treatment criteria that can help clinicians to determine to make the decision for treatment eligibility for their patients. And today I will be focusing on only a few, but here I have the European criteria, EASL, which is based on HBV DNA for viral replication and FibroScan for liver fibrosis. So the gold standards really that are needed in settings to measure those two aspects. However, given that HBV DNA and FibroScan are not available in some settings, there have been simplified treatment criteria that have been suggested to replace HBV DNA and FibroScan. And here the WHO has also contributed to this work by providing the guidelines in 2015 and has updated also the guidelines in 2024 and has suggested to use an APRI score, which is a score that is based on AST and platelet count. These two tests are less expensive in research settings, and this score can be used to stage fibrosis when FibroScan is not available. So in addition to the WHO guideline that provides the APRI score, these guidelines also suggested to lower the viral load threshold, but also to include all the fibrotic patients and all adolescents, adults and adolescents in the treatment eligibility decision, given that in the previous guidelines, there were a lot of patients that were missed, and the WHO wanted to make sure that everyone would be included, also due to human rights issues that the cutoff that were suggested previously were removing some patients. In addition to the WHO guidelines, two other guidelines, TREAT-B and HepsaNet, were developed from clinical studies, and these studies came up with a way to base treatment eligibility decision on available and less expensive tests. So TREAT-B is based on HBe antigen and ALT, while HepsaNet is based on platelet count and ALT and AST. However, what you can see in this is that all the treatment eligibility criteria are based on more than one single test, and they all assume that these tests would be available simultaneously once the patient presents to the hospital, which is really not the case in resource-limited countries where patients, first of all, the tests are in charge of the patient, so they're out-of-pocket expenses, but additionally, there could be other delays due to them understanding what are the requirements to get all those required tests. So here in this study, we wanted to address first the delays that could occur in HBV diagnostic tests, given that these have not been analyzed in previous studies. Additionally, the newly suggested APRI cutoff, so the score that is used to stage fibrosis when FibroScan is not available, has not been validated in an African country. So we wanted to do that in this study. And we also wanted to understand the relevance of the treatment eligibility expansion. So as I said, not only did they revise the APRI cutoff in the new WHO guidelines, but they also lowered the viral load and included all fibrotic patients when in the previous guideline, only cirrhotic patients were eligible. So the objective of our study was first to describe the delays in completing each test, secondly, to estimate the diagnostic accuracy of this cutoff of 0.5 to stage significant fibrosis, which indicates F2 in the stages that are shown before, compared to FibroScan, which was our reference test. Third, we wanted to evaluate the impact of the time interval between APRI test and FibroScan on the discordance of their results in staging liver fibrosis. And finally, we wanted to assess the agreement level of the treatment eligibility criteria using ISO 2017 as our reference standard. So in terms of methods, so we carried out a retrospective cohort study of all consecutive patients with chronic hepatitis B that were followed at the hepatogastroenterology service in Bogodogo University Center Hospital, which is in Ouagadougou, the capital center. From these patients, the data came from patients who were followed from 2014 to 2022. And this includes patients who had seen a prior visit with a general practitioner before they are referred to Bogodogo, or those who came directly to Bogodogo University Hospital. And at the initial visit, when they came to the hospital, patients were administered 5 tests, HBV DNA, so viral load, FibroScan, HB antigen, transaminase, which included ALT and AST, and platelet counts. So here we had data on first visit date, test results, and corresponding dates, personal information such as age and sex, and other clinical information such as whether they had signs of decompensated cirrhosis, like jaundice, or if they had a family history of cirrhosis. And in this analysis, we excluded patients who were aged less than 18 and those who had an HIV or hepatitis C co-infection. So just illustratively to show who is included in this study, here scenario A, B, and C represents patients who had a prior visit to before joining Bogodogo. And scenario E and F, G represent patients who came directly to the hospital. For all these patients, they had 3 outcomes for each test. So either they completed the test before the end of our study, so June 2022, or the test was not completed, or they were lost to follow-up. So this scenario was just designed to show the different scenarios based on one test. In terms of statistical analysis, so we conducted a Kaplan-Meier survival analysis with the event of interest being test completion over 3 years of follow-up. And here we restricted this analysis to only patients who had a direct initial visit to Bogodogo. Secondly, we estimated the sensitivity, specificity, as well as the area under the receiver operating curve for the APRI cutoff of 0.5. And we also looked at the impact of the delay. And here, when I mean delay, we defined it, given that APRI test is based on 2 tests, so AST and platelet count, we defined the delay as the time interval between FibroScan and each of the tests that compose APRI score. And finally, we calculated the Cohen's kappa, which we used to assess the concordance between different treatment eligibility criteria. Here, all the analysis were done using RStudio. In terms of the main findings, so after exclusion criteria, we remained with 609 patients, and our sample was actually quite young, with a median age of 34, and more than half of the patients were male. The majority of the patients that came had a prior visit before Bogodogo, so only 26.6% had a first direct visit to Bogodogo. But most interestingly here, when we look at test completion, we saw that the majority of patients were able to complete the 5 required tests. So as you can see, even for the tests that we assume would be hard to get, viral load and FibroScan, they still had an 85 and 87% test completion. However, while these percentages are high, the median time completion of all the prescribed tests was also really high, with a median time completion of 400 days, which is more than a year to complete the 5 required tests. These results show the results of the Kaplan survival analysis. And here what we are looking at is the probability of test completion over time for each of the 5 recommended tests. So transaminase in red, FibroScan in orange, HBE antigen in purple, viral load in green, and platelet count in blue. And the main interesting finding here to us was that even after a year from their first visit, patients kept coming back for the required test. And the test completion, even after a year, the increase ranged from 4.8% to 22% increase in test completion after a year from the first visit, showing really patient commitment to get the required test. Another interesting finding was that for the patients, for the tests that are harder to get, so FibroScan and HBV viral load, so DNA, there was lower test completion over time. So as you can see, compared to transaminase, so as you can see, transaminase was higher, and then FibroScan and viral load was low. And here platelet count, which can be surprising, was the lowest, even though it's also an accessible test, was very low compared to all the other tests. But this was due to the hospital, when they're assessing eligibility, when we asked them what criteria they were using. So they were using the European criteria before 2019. And after 2019, they were using the national recommendation, and none of them required platelet count in the treatment eligibility assessment. So if the clinician had to prioritize some tests, they prioritized the 4 tests over platelet count, which helped us to understand why platelet count, even though it's accessible, still had a lower test completion over time. When we looked at the impact of the delay on APRI diagnostic accuracy, so first we looked at the APRI cutoff sensitivity and specificity in the whole sample. And what it showed was that this cutoff had a sensitivity of 39.5%, which means that 60% of the fibrotic patients would be missed, which is really high in this setting. However, we get to see that this low sensitivity is also due to the delays in accessing the test. So as you can see here, this shows the stratified analysis. When we looked at patients who had the test within 3 days, 3 days to 1 month, 1 month to a year, and more than a year, we can see that the sensitivity improves if patients take tests within 3 days, but then keeps becoming lower if patients take tests with an interval of more than a month to a year, or even more than a year, which shows really the negative impact of the delay when using APRI as the diagnostic test to stage fibrosis. Finally, we looked at the treatment eligibility criteria to understand the relevance of the WHO guidelines. And when we compared it with the European criteria, which was our reference standard, as I mentioned, it showed low concordance with the European criteria of 0.36. This is on a range from 0 to 1, 1 showing high concordance, and showed very low specificity of 59.5%. This means that 40% of the patients would be treated when they really do not need treatment. When we then looked at the TREAT-B and HepSanet, which are the 2 scores that I mentioned were developed in the context of resource-limited settings and use less expensive tests, they showed higher concordance with the European criteria, with high sensitivity and specificity that is above 80%. And so what we saw here was that the WHO had many false positives, which would lead to overtreatment of the patients. In terms of the implications of the study, So as I showed, patients really experience long delays in completing all the prescribed tests. However, we can see that more than 80% would eventually complete FibroScan and HBV DNA despite the cost. So it's very important to continue encouraging HBV and DNA and FibroScan as first lines to for treatment eligibility assessment, especially in urban settings like Ouagadougou in Burkina Faso, which is the capital city and where patients could still get these tests. Secondly, we saw the negative impact of the delays on accurate fibrosis diagnosis, and it's very important to address the delays. And this can only be done if the HBV tests are subsidized for patients with chronic hepatitis B, as at the moment, the patients with only chronic hepatitis B have to pay for these tests out of pocket. And the other finding was that the newly developed WHO guidelines, while it was meant to ensure that all patients that are eligible would receive treatment, they would lead to overtreatment in a setting where antiviral treatment already experiences some frequent stockouts in the country, but also where access to diagnostic tests is limited, as we can see in this study. So our study showed that TREAT-B and HepSanet in settings where HBV DNA and FibroScan would serve as better alternatives compared to the WHO guidelines to determine treatment eligibility criteria. And finally, to be able to achieve the WHO elimination targets to eliminate viral hepatitis, it is very important to increase access to diagnostic tests and treatment, especially in resource-limited settings like Burkina Faso. Yeah, so I would like to acknowledge quickly Dr. Alice Kagengane, who is the hepatogastroenterologist who collected this data and was kind enough to allow me to work on this data. Dr. Yusuke Shimakawa, who is my professional advisor and guided me through this process, and the unit that has hosted me over the past 4 months, and also Dr. Jus Gungugane, who is my academic advisor at EHSP. Thank you so much for listening.
Thank you very much, Nicole. We have a first question from Romulus.
Hi, thank you for the talk. I just have a quick question. Can you comment on the cost of diagnosis relative to the yearly cost of treatment?
So currently the tests, so in Burkina Faso, if all the tests are out of pocket, so HBV DNA and FibroScan are around 40 euro. So that's about 80 euros. And you add the other tests, which is about 10 euros. So for only the 5 tests that are required for treatment, it would take us to 130 euros per patient. In terms of treatment, I believe it depends on the social security. If you are low income, you do receive some subsidies in terms of the treatment, since it's a lifelong treatment. However, if it's out of pocket expenses, then it would be also about 100 euros per year for the cost of the treatment.
Okay, thank you.
Any other questions? So I have one, Nicole. So you spoke about the importance of delay until doing the test. Just that, do you conclude this statistically, or because there's a trend in the sensitivities? I was not completely sure on the slide.
Yes, so we concluded that based on the impact on sensitivity and specificity. So as I showed, if the tests are taken within an interval of 3 days, while it's still not perfect, the sensitivity is about 60% for that APRI score. But if then there is a longer delay, it drops down to 30%. And that could be due to the natural history of disease. So if someone has taken AST today and then take the platelet count in a year, there is a change in the natural history of the disease, and that impacts as well the accuracy of the score as a whole to stage fibrosis.
Yeah, I was wondering about, is this difference statistically significant? So you had p-values, but I didn't understand how they went, and I just saw quickly that the confidence intervals around the estimates were actually very large.
Yes, so we compared the OROC values. There was
you can share slide, I think it was slide
Yes.
15, if you can share it again.
I will share again. Yes, so as you can see here, what we did was compare the OROC for the time interval. So our reference here was those who had taken a test within 3 days. So we compared the OROC in terms of the time intervals, the delays. So here we can see that there is a statistical significant difference in OROC for those who had completed the test within an interval of 1 month to a year compared to those who had done it in 3 days, and also a statistical significant p-value if you look at more than a year compared to within 3 days.
Okay, I see. It's just if you look at the for sensitivity, because there's not much change on specificity, but if you look at sensitivity, of course, the confidence intervals are so wide that, yeah,
yes,
it seems sort of a stretch to interpret that there's something major happening. But I see, so that's the p-value for the OROC. Okay.
Yes.
Makes sense. Where, there's less overlap. Okay, thank you. Is there any other questions? One comment, please, from the colleagues. So OROC is area under the curve. I hope everybody is clear on this. What would you suggest the next steps for research, Nicole?
So currently the European criteria have been updated. So we are planning to incorporate that into our new analysis. But we also, at the moment, we had done a complete case analysis. So we are trying to also do some sensitivity analysis looking at multiple imputation and see whether these results would remain significant, especially when it comes to the delay, because as you mentioned, it might not be like as clear, but we would like to do the different sensitivity analysis to see whether these results remain significant.
Okay, thank you very much. It's 2:30, so maybe we can indeed switch to the second presentation. Thank you very much, Nicole, again.
Thank you so much for listening. Bye.
And so, Laura, je te donne la parole pour présenter le travail de Satria.
Ok.
Ou introduire le travail.
Oui, je ne vais pas présenter le travail de Satria, on va le laisser présenter tout seul. Ce sera en anglais aussi, je pense, Satria. Oui, oui. Enfin, comme tu veux, bien sûr, mais voilà. Ah non, tu l'as fait en français?
Je suis en français.
Ah d'accord.
Non, mais j'ai déjà préparé un script en français. Peut-être je voulais essayer de faire en moitié de la présentation en français, mais le résultat, je vais présenter en anglais juste parce qu'il y a trop de thèmes techniques que je ne peux pas traduire en temps. Donc, si c'est bien pour tous, je voulais vraiment avoir la chance de faire ça.
D'accord, donc on aura une présentation en franglais de la part de Satria.
D'accord, franglais. Oui.
C'est ça. Qui a fait son stage dans le laboratoire, qui n'a pas tout à fait terminé d'ailleurs, avec Karim, ici présent, et moi-même. Voilà. Satria, quand tu veux.
Merci.
Je vais mettre en plein écran.
Oui. Excusez-moi, est-ce que tu peux voir mon écran à ce moment-là? C'était la présentation. OK, parfait. Excusez-moi, attends. Ah, excusez-moi, je vais juste redémarrer la présentation. OK, c'est le premier slide. Oui. OK,
C'est tout bon, merci.
OK. Bonjour à toutes et à tous et merci d'être présents aujourd'hui. Je m'appelle Satranou Chaban et j'ai le plaisir de vous présenter les résultats de mon mémoire de recherche intitulé Déterminants de l'antibiorésistance en milieu hospitalier. Ce travail a été réalisé en utilisant des données de l'hôpital Saint-Joseph Saint-Luc à Lyon en collaboration avec Dr. Kim sous la supervision de Laura et Karim de Selabo. Et donc, c'est les 5 parties de cette présentation que je vais faire. Je vais commencer par un petit contexte et une petite explication de la problématique. L'antibiorésistance ou RAM, AMR en anglais, est un problème majeur de santé publique à l'échelle mondiale. Elle se produit lorsque les micro-organismes développent des mécanismes de défense face au traitement antimicrobien. Cela engendre des conséquences graves, comme prolongation des hospitalisations, des échecs thérapeutiques sous coût important pour les systèmes de santé et des milliers de décès supplémentaires chaque année. En Europe, on estime à 35 000 le nombre de décès par an liés à le RAM et à 874 000 le nombre d'années de vie corrigées de l'incapacité ou dailies en anglais, AVCI en français, qui a causé environ 1,5 milliard d'euros de pertes économiques, soit directes, soit indirectes. Il y a plusieurs interventions contre RAM qui sont utilisées à travers du monde. Première, c'est la stratégie générale de l'OMS qui consiste à sensibilisation de l'antibiorésistance au sein de travailleurs sur l'hôpital et aussi le travailleur de santé en général. Le deuxième, c'est la surveillance et recherche pour lutter contre le RAM. Le troisième, c'est soit le mesure d'hygiène en milieu hospitalier. Le quatrième, c'est l'usage rationnel des antibiotiques. Et le cinquième, c'est la promotion d'investissement durable dans les médicaments, dans les nouveaux médicaments. Ce qui nous concerne dans ces recherches-là, c'est le programme de bon usage antibiotique, ou en anglais, c'est Antimicrobial Stewardship Programs, qui est défini en tant que optimiser l'usage des antibiotiques pour des meilleurs résultats de patients. Et on le fait par la création de protocoles et guidelines de prescription, les audits et rétroactions au milieu hospitalier ou dans une facilité sanitaire. Et le troisième, c'est la formation et éducation de travailleurs sanitaires, que ce soit médecins, soit infirmières et toutes les autres parties de ce domaine-là. Maintenant, je voulais partager une histoire d'une intervention réussie au sein de l'hôpital Saint-Joseph Saint-Luc. Dans cette intervention-là, l'antibiotique ciblé est le ceftriaxone et le cefpotaxime. Et l'objectif de cette intervention, c'est de réduire la sélection d'enterobactéries résistantes. Le résultat qu'on recherche précédent à trouver, c'est que l'intervention hospitalière a significativement diminué l'incidence de ESBL, or the expanded spectrum beta-lactam producing Enterobacteriaceae. Maintenant, je vais partager sur cette diapositive, on peut voir la frise chronologique ou le fil de temps de notre étude. Le point d'intervention a été fixé en janvier 2014, tandis que la période liée à la pandémie de COVID est définie comme s'étalant de 2020 à 2023. La question de recherche 1 et 2 porte sur la période 2011 à 2017 dans le but explicite d'éviter toute interférence avec l'effet du COVID-19. On voulait isoler l'impact de l'intervention sans biais lié à la pandémie. En revanche, les questions 3 et 4 couvrent la période 2017 à 2023 afin d'analyser les effets spécifiques liés au COVID-19, notamment sur les prescriptions antibiotiques et les profils microbiens. Sont nos questions de recherche. Au total, on a construit environ 76 modèles pour répondre à ces 4 questions, mais en raison des contraintes de temps, on va se concentrer uniquement sur certaines combinaisons spécifiques pour chaque question de recherche. La première question, c'est entre intervention et antibiotiques cibles. On va se concentrer sur céfotaxime et ceftriaxone dans le département de réanimation. La deuxième question de recherche, c'est sur l'effet d'intervention sur le profil microbien et on va se concentrer sur le ESBLE et céphalosporine 3e génération résistant en réanimation. Pour la troisième question, c'est pour évaluer l'effet de COVID-19 à la prescription antibiotique. Et ici, on va concentrer sur la consommation totale d'antibiotiques dans le département de médecine. Et la dernière question, c'est l'effet de COVID-19 sur le profil microbien au sein de l'hôpital. Et on va se concentrer ici sur l'incidence de hypercase et céphalosporine 3e génération résistant dans le département de médecine. Notre méthodologie, notre study design, nous avons adopté un design observationnel rétrospectif, monocentrique et longitudinal. Les données ont été recueillies sur une période de 13 ans avec plus de 50 variables analysées à l'échelle départementale sur consommation d'antibiotiques, durée de séjour, infection microbienne, nombre de patients, chimiothérapie, dialyse, patients COVID, etc. Les analyses incluent des statistiques descriptives, des tests de Wilcoxon, des régressions linéaires segmentées. Segmented regression is the interrupted time series et des régressions de Poisson avec estimation généraliste or GEE approach. Alors, c'est ici que je vais passer en anglais, je crois. Here you can see that there are 3 different groups of variables. The first one being logistics, antibiotics, and microbials. And this is just a snapshot of which types of variables we include in our study. Now I will start to discuss our findings. The first one being, let's start with the first one being the effect of intervention on the specific prescription patterns. The methodology for all 4 different questions are generally the same. So we start with a descriptive analysis where we go through a general descriptive summary of the antibiotic consumption, and we evaluated the mean and standard deviation of each consumption. And afterwards, we conducted inferential analysis, a pairwise first using Wilcoxon-Rank-Sum test. And because this is an intervention and it sort of fulfills most of the assumptions necessary, we use the interrupted time series with a basis in multivariate linear regression. And here on this slide, you can see that based on only descriptive graphing, this is a time graph of the usage of cefotaxime in red and the usage of ceftriaxone in gray. You can see that there is a clear step change at the point of intervention, at least within 1 or 2 months of the intervention of cefotaxime, and a step decrease, again consistent and within 1 or 2 months of the intervention of ceftriaxone. The same can be seen also in medicine, even more clearly than the ICU, which is already an interesting result on its own to show the efficacy, not the efficacy, but the success of the intervention. And here are some of the regression models that we created, focusing on the cefotaxime and ceftriaxone in the ICU. You can see that in the cefotaxime model that there is a step increase of 442.04 DDD per 1,000 bed days. DDD is the daily defined dose of cefotaxime consumed, which is shown to be connected to the output, which is the cefotaxime, the usage of the consumption of cefotaxime in the ICU. This is also reflected in the reduction of ceftriaxone. Another interesting result here is that duration of stay so average duration of stay and the number of patients in the ICU also contributed to the consumption of cefotaxime. Here we found a persistent effect post-intervention until the end of study period. As you can see, there are no significant relation with time post-intervention trends here in this line, which I believe is one of the proof that we can conclude this first statement from. And this findings replicate a previous study done in the same hospital with Dr. Kim and Karim, and supports the continued and therefore supports the intervention of the implementation of the intervention. The second question is on the effect of the intervention on the microbial infection profile. It's the same descriptive analysis methodology and the same inferential statistics as well. And here we're focusing on the third generation cephalosporin resistant strains, as well as the ESBLE, or the extended spectrum beta-lactam producing enterobacters. And in this case, it's just a general trend to show you how it looks like, but the more interesting result is seen in the regression model. And here you see that there is a decrease with the intervention of extended spectrum beta-lactam producing strains, even after controlling for the number of sort of community ESBLE as represented by ESBLE screening, which is the screening for these types of resistance in patients coming into the ICU upon their admission. And it is also seen to be connected to ciprofloxacin use, penicillin type A use, and duration of invasive ventilation. And the 3GC resistant is intervention. It shows that also the resistant strains, there's a reduction with the intervention, and the association between the two appears to be significant. And here we see that the reduction of ESBLE incidence once again reflects the findings of Kim's study from a past study in the same hospital, and supports the finding of a past cluster randomized trial by Bouillet et al. That supports sort of shows that changing cefotaxime, ceftriaxone to cefotaxime reduces the selection of this resistant strain. Another added benefit is that a similar intervention has been known to reduce also other type of resistant mechanisms, even though they're not directly connected to the drug itself. The third one, COVID-19's effect on antibiotic prescription pattern. Just as a reminder, we now switched the study period from 2011 to 2017 to 2017 till the end of the period of the study, which in this case is end of 2023. Sorry, 2019, what am I saying? The methodology, again, for the descriptive analysis is the same. However, for the inferential statistics, because this is no longer an intervention, but rather sort of a global pandemic with a lot of like spillover effects, we decided to just use a simple multivariate linear regression. And here you see that visually there seems to be an increase and then a slight downward trend for total antibiotic use in the medical department, and an increase in hydroalcoholic use at the during the COVID pandemic. These results were confirmed using the regression model. The total antibiotic consumption, you can see that the COVID-19 here is represented as a continuous variable of number or incidence of admitted patients with COVID in the hospital in that particular ward. And here you can also see that on top of COVID patients, the incidence, the total consumption of antibiotic is also positively associated with people moving from the urgent care. And hydroalcoholic medicine is seen to increase with time, but very significantly increased with the number of COVID patients admitted. It seems to also increase or associated significantly with patients that are, or the incidence of patients that are above 80 years old. Now, hydroalcoholic solution, the findings with hydroalcoholic solution mirrors numerous other studies from past studies, also in Europe in this case. It is most likely driven by early pandemic hygiene focus, and it is supported by increased adherence to hand hygienes. Hygiene measures reduce hospital-acquired infections and subsequently minimizes unnecessary antibiotic usage, which is a policy that we would like to promote here. The increase in total antibiotic use is most likely explained by broad spectrum use during early COVID-19 period, as doctors and caregivers scrambled to prevent secondary infection or thought that COVID was actually a bacterial infection in the beginning. Some of the findings matches national French trends during COVID, but patterns may be different slightly to similar past papers due to the hospital's nature of Saint-Joseph-Saint-Luc, which is a non-centre hospitalier universitaire in this case. And there's a difference in impact difference of impact in COVID, at least period-wise, which received the brunt of the first wave, whereas this hospital has been known to be most affected by the second wave. Question number 4 is the impact of COVID-19 on microbial infection pattern. And the methodology in this case is the same for descriptive, but for the inferential statistics, we chose to use a Poisson regression with a GEE approach. So we kept the detected microbials as count data. And here you see a trend of increase in the hypercase infection in medicine, and also a trend in increase in third-generation cephalosporin-sensitive hospital-acquired infection within the medical department. We confirmed this through the process of a regression model where we saw an increase of around 4% in of the incidence of hypercase infections or hospital-acquired infections with each unit increase of COVID patient, with each incidence increase in COVID patients admitted. It is also seen to be related to, this is just like due to the rounding. There's actually like a lot of number behind it. So hydroalcoholic solution, chemotherapy, and the age of the patient. So in this case, it's the median. And for the third generation sensitive hospital-acquired infection, we see that there is a slight decrease as more COVID patients appeared, but it's also related to penicillin type A, death, and in a duration of invasive ventilation. Again, the numbers seem very small because the COVID administration variable is a continuous variable. Therefore, but because IRR by its nature is comparing the ratio between two different risk and non-risk group or exposed and non-exposed group. So in the subsequent steps of our study, we would probably try to convert COVID into factor variable as opposed to a continuous variable, just to be able to represent it better with this particular measure. Yeah, so again, this confirms that COVID-19 was significantly associated with changes to infection patterns, which is our general question. It's not about looking about the increase or decrease, but that there is a significant shift to infection patterns, which necessitates, therefore, a different approach to care, to stewardship, as well as to surveillance. This confirms results of a past study in Brazil, where profiles also significantly shifted post-COVID-19. And is important to connect with other studies where we have found that mortality has been shown to be increase in multi-drug resistance. In our study, this has yet to be confirmed, as death was not set as an outcome, and we caution as well that there may be a risk of misinterpretation or reverse causation with some of the predictors. Now, in terms of the qualities of the study, je vais passer en français encore pour cette partie. Maintenant, un mot sur les forces et limites de notre étude. D'un côté, on a plusieurs forces méthodologiques importantes. On a utilisé une méthode de série temporelle interrompue, ce qui est recommandé pour les études d'intervention, car cela permet une inférence causale plus solide. Le deuxième point, c'est qu'on a aussi mobilisé un modèle de Poisson avec estimation GEE, qui nous a permis de contrôler l'autocorrélation et la surdispersion du problème fréquent dans les séries temporelles en santé publique. L'étude repose aussi sur 13 années de données, ce qui donne une vue d'ensemble robuste, rarement atteinte dans ce type de recherche. Et enfin, on a défini la variable COVID de façon contextuelle et locale, en tenant compte de la réalité du terrain plutôt que des périodes nationales standards. Mais bien sûr, il y a aussi des limites à reconnaître. Première, soit la collection de données n'a pas été constante. Tout au long de 13 années, il y a eu des changements dans les synthèses, les personnels, les définitions, ce qui peut introduire du bruit de données. Le deuxième, c'est qu'on a travaillé on travaille avec des données écologiques, donc sans accès de données individuelles ou qualitatives. Le troisième, c'est que c'est une étude monocentrique et observationnelle dans un groupe de contrôle, ce qui limite la généralisation des résultats à d'autres contextes. C'est presque ma dernière diapositive. Je voulais juste expliquer la conclusion qu'on a trouvée depuis cette étude. Le premier, c'est que le changement politique a eu l'effet de société et cet effet s'est maintenu dans le temps. Le deuxième, c'est que l'intervention a réduit les sélections de microbes résistants. Le troisième, c'est que le COVID-19 a modifié significativement les schémas de prescription, entraînant une hausse globale de l'utilisation d'antibiotiques. Et le quatrième, c'est on a trouvé que le COVID-19 a provoqué un changement dans le profil microbiologique dans cet hôpital. On avait 3 recommandations à donner depuis cette étude. Le premier, c'est d'appliquer l'intervention à grande échelle dans plusieurs hôpitaux, bien sûr, après une série des études plus grandes, multicentres, et peut-être même des études économétriques pour évaluer l'efficacité, comment dire, like ICERs, de cette intervention. Quand on s'applique globalement. Le deuxième, c'est d'améliorer la gestion du changement au niveau hospitalier, notamment pour l'infrastructure de collecte des données. Et le troisième, c'est de poursuivre les recherches pour évaluer l'interaction entre le COVID-19 et l'intervention. Et avec ça, c'est la fin de ma présentation. Merci pour votre attention.
Merci, Zafria. Bravo pour le français, là. Des questions?
J'avais une question, du coup, Zafria, comme tu parlais du Inconsistent Data Collection, est-ce que tu as pu voir plus justement ce qu'il pouvait y avoir comme bruit? Parce que du coup, donc, au niveau de l'hôpital, il peut y avoir des changements sur la manière dont ils testent ou non certaines résistances, il peut y avoir des changements sur les antibiotiques qui sont administrés en priorité ou pas, et comme tu disais, après, il peut y avoir des changements dans le personnel et tout. Est-ce que tu as une idée un petit peu de ce qu'il y a pu y avoir comme changement, du coup, à l'échelle de cet hôpital spécifiquement?
Je suis vraiment désolé, le micro n'est pas très bon, donc est-ce que vous pouvez juste répéter la question en anglais, s'il te plaît?
Okay, well, no worries, I'll switch to English. So my question was on the data inconsistency that you mentioned. So there, as you said, there could be a lot of different reasons for that. So either hospitals might change the testing regimen that they apply to test for different resistances, or they could change for the antibiotics that they use, or you have personal changes. So all of that's going to play. But do you have an idea for the hospital that you looked at specifically as to what these data inconsistencies might be and how they might impact your results?
Yeah, so in this case, the problem with the data collection is that there is a device change, software change, where they collected the data with a different software. And I think it was not that some data were lost, it was just that it would be extremely difficult to obtain data from before the shift in the device. So that means we were only able to benefit from the data that was collected for a previous study in the way that it was collected. And then in the second period, due to both the device, I think the software change and also some policy changes, some information was collected differently that forced us to sort of exclude some variables due to these differences. However, we have been in close contact with Kim in the hospital, where we tried as best as we can either to find the same data or to find an equivalent variable that could to act as a proxy variable to explain to answer certain parts of our question. Another one is also I think it was a personnel change. I think this also reflects sort of the social aspect of research and the importance of building connections, because the past person in charge of the collection in the pharmacy department knows very closely the type of the study, sort of how it was done, what data was collected, and the current person sort of did not know exactly how to provide it in a way that could allow us to use them easily. And it created some barriers, some time changes. We had to change our timeline because we were waiting for certain type of data, and there were additional issues with sort of finding out in the end that, oh, apparently these two data are collected differently, which is why we had to, for example, shift not use the measure of central tendency when comparing the whole period, because the first period was average, the second period was median. It was these sorts of like small miscommunication, difficulty in like taking certain data that I think was what we faced. And the way it affected the data in our study is that it sort of just reduced the granularity, because we didn't have certain variables that we could have had if the data was collected in the same way by the same person. And there was also another issue, which was mainly that it became limited. It limited our study. It limited the granularity and the number of variables we could have included in our study. I don't know if that's the answer you were looking for.
Yeah. So just to recap, what you're saying is it's mostly a technical difficulty with that system change and that personal change. What I would recommend though is you just check throughout the data if you see differences in the testing strategy within hospital, because that can change over time. So for example, they're going to routinely test for resistance to one antimicrobial for a couple of years, and then suddenly stop testing for that, and that will impact your perceived resistance prevalence. So keep an eye out for that. But other than that, it's fine. Thank you.
Yeah, it was also one of our weaknesses in our study that, like, especially during COVID, there could be a testing bias where certain diseases were tested more frequently than others, which we already reported, but perhaps I didn't include in the paper. Thank you so much for the question, Constant.
D'autres questions? No?
Maybe one question from my side. So this change in prescription practice during COVID, do you have any data here that come with this data set that would allow understanding whether this was really, clearly indicated because, the gravity of the clinical conditions, or whether there's a change in prescription behavior from the physician? So, I mean, I'm thinking of, prophylactic antibiotic prescriptions that could be more frequent if patients are in more severe conditions. Also, there may not be clearly an infection, a bacterial infection that needs to be treated.
Yeah, I mean, I suppose that is our because the study is fully quantitative, there wasn't sort of any official or qualitative element to it where we could ask the doctors in the hospital whether there were any changes to their prescription practice. We did talk with Kim, who is our collaborator in the hospital, and the data owner in this case. And yeah, there was indeed a change in prophylactic use in the beginning, which in the case of this hospital was not following, for example, the trends in some other hospital with azithromycin. But to answer your question, there wasn't. I checked with the contact in the hospital as well. There wasn't any big policy changes, big official policy changes for prescription within the period of COVID. It was only sort of like the step changes that they do following the recommendation of the French Santé Publique and WHO, but there was no big changes. And also, like, I need to clarify that we did not check yet the interaction between intervention and COVID-19 because we did separate the two periods of study. Yeah.
Okay. And do you have any idea of a variable that should be added in such data collection efforts, or databases in the hospitals that would help to appreciate these kind of effects?
Yeah, for sure. I think it's not so much as a variable that could be added in data collection. For me, it would be the design of the study, because as much as doctors do follow national guidelines, from my experience, there has been certain types of personnel or professional or kind of like department to department variation in terms of preference in treating certain drugs. And so I would love to see sort of a mixed methods approach in this case, where we do go to the ground, we discuss with the practitioners there, we talk about, you know, sort of and all levels, not just the attendings, but also the residents, the trainees, because these types of variants, in my opinion, is very significant, and can definitely inform more about whether or not these types of effect is just normal variation, whether there's a difference between department, and kind of like sharpen our estimates with contextual information. I don't know if that answers your question.
Yes. No, I'm just wondering whether there's an elegant way to collect data that sort of indirectly show or help you to understand. Sometimes it's better to have the data rather than ask people, because, you know, on these kind of things, people may not,
may not say that.
Sometimes it's better by showing through some data evidence that there's something happening.
But we'll note that down. We're still going to be continuing with this project, so I will also reflect on that as we continue, and by the end, hopefully when we publish, that could make its way into a recommendation if we think of anything else. But thank you so much, Judith, for the question.
Ok, on est à 15 heures, l'heure de s'arrêter. Laura, on n'a pas encore de programme pour l'année prochaine. Hein. Il va falloir qu'on s'accorde sur les dates. Les volontaires, donc tous ceux qui sont en ligne, n'hésitez pas déjà de réfléchir à ce que vous pouvez présenter.
Exactement, pareil. On va vous laisser réfléchir à ça. Nous, on vous partagera un programme en termes de planning, c'est-à-dire ce sera toujours à peu près les vendredis en fin de mois, a priori, mais voilà, on va trouver les bons vendredis. Et puis, pour ceux qu'on ne revoit pas, on va vous souhaiter des bonnes vacances d'été. Hein, c'était la dernière session en septembre, donc voilà. Bon après-midi. Et voilà.
Merci. Bye bye.